Here is a case of large volume RIRS, partial staghorn with FANS Sheath RIRS is done. 36-year-old male patient incidentally detected left renal calculus 34 into 17 mm and 11 into 11 mm in the upper pole. Actually, volume is high. If you see in the CT, it looks horizontally located stone with two stones in a dilated calyx. You can see here quite large horizontally stone. Access sheath has gone directly without prior stenting. After keeping the RIRS fans access sheath, we thought we will do supine PCNL because of large volume stone. This is the needle direction already coming about the 12th rib in this direction. If you go parallel to the stone lying calyx, it will go above the 11th rib. So we decided to do with RIRS, and then already by the time access sheath is there nearer to the upper calyx, we proceeded successfully. RGP has clearly shown long stone in the calyx and two stones. We thought we will do PCNL, but because anyway the access sheath flexible has gone inside, we went and kept 1.5 and 15 hertz, and quickly, actually Hounsfield units were 1300, so quickly we started breaking, not exactly powder, we made into the pieces, and all these pieces spontaneously was sucked between the access sheath and the flexible scope. In between, few times only the flexible scope is removed from the access sheath. The important point is the tip of the flexible access sheath is kept at the infundibulum, and we have digged into the stone, made the stone weak. This is not usual, where we in routine RIRS we don't make the stone weak, we don't make the fragments, whereas now because of the FANS access sheath, purposefully we make the stones fragments and then break them in a little pop dusting mode so that all fragments will come out. Once we entered the infundibulum of the medial calyx, two stones were there in a dilated system, and once they are pushed into the system, again access sheath is pushed into the long calyx and then continued. The advantage of the putting the access sheath into the long calyx is the water flow logistics will be better, and scope also need not be bent again and again. After doing certain stone, here see stone is situated in the anterior, so we have completely rotated the flexible scope anteriorly and broken the stone. After breaking the stone, infundibulum was opened. See, this is the way the one more infundibulum and the secondary stones are formed. These secondary stones we might have needed the PCNL second puncture, because initially we planned a PCNL puncture, they were parallel calyces. Now see, the large stones are sucked out through the access sheath. With this, time taken for removing of the stone will be very, very less than making powder and leaving the powder. So as the stone volume decreases, the access sheath movements improve, and every small stone in the paracalyx grooves can be flushed. And see, this is another secondary stone pulverized very fast with 2 watts and 15 hertz. Water continuously outflows, so the chances of heat formation will be less. In between you can suck the water also, otherwise water will be continuously drained by the access sheath. Active suction will helps to remove the water intermittently completely, and thus chances of the intrarenal temperature rise will be very less. Even then we have not crossed. See here, we are sucking intermittently all the fragments. These fragments are 3-dimensional fragments, not powder, so the volume sucked out at each point of time is very high, and thus the clearance of the stone is faster. So by any means, if the access sheath is accessible to the calyx, if the stone is seen all around, large volume stones, this technology will help a lot. At the end, a lot of the times when you use for 15-20 minutes, the stone powder forms a sort of dust over the calyx and it won't be removed. In these cases, you can graze with the wall of the flexible scope and flush with water with a little bit of laser, moves that settled dust, float, and then that will be sucked into the mouth of the access sheath. All these things will decrease the nidus for future stone formation, and thus definitely this type of dust sucking will avoid the stone formation again. And also immediate stone free rate is very high with this form of the FANS access sheath. So here is a long infundibulum of their calyx. The puncturing these type of calyces obliquely is difficult, and if you cannot reach the parallel calyx stones, 2 punctures may be needed. At the end, lot of powder has come along with the fragments, and then we entered and seen complete clearance was noted. No visible large fragment is seen in the pelvic calyceal system. We have also gone, especially the stone impacted in a deep calyx, chances of the fragments going into the other calyxes also is very less. So here again, moving with the scope, the fragments, and then sucked out all the possible fragments. With this, our relook rate is decreased. In this patient, see, dilated calyx is visualized at the end, and non-damaged horizontal calyx is visualized, and lot of collected stone material can be sent for analysis. To conclude, large stone volumes are treated now with FANS sheath and RIRS, giving good results provided ureter is accommodable, distensible, and adjustable to the flexible access sheath up to the PUJ and up to the calyx. Thank you.